A 27-year-old, otherwise healthy female who traveled to Brazil 2 weeks prior to presentation, complained of high fevers, chills, malaise, exertional dyspnea, and cough. The patient was a graduate student who had undertaken a research project in an old cave region for the previous 2 months. She did not use any contact or airborne precautions. Her team entered a large cave that housed bats. In the cave, she collected bats and bat droppings. The patient had no significant past medical or surgical history. Her family history was not remarkable. On physical examination, the temperature was 37.8 degrees Celsius, heart rate was 92 beats per minute, blood pressure was 116/80ths of a millimeter of mercury, respiratory rate was 16 breaths per minute, and oxygen saturation was 99% breathing room air. She was in no acute distress, breathing comfortably, and the lungs were cleared to auscultation bilaterally. No lymphadenopathy was detected. Laboratory investigations revealed normal CBC and metabolic panels. Her chest X-ray revealed a diffuse miliary pattern throughout the lungs without pleural effusion or pneumothorax. So, based on the clinical scenario, what is the most probable diagnosis? What other laboratory tests would help guide your diagnosis? You are provided with results of the laboratory investigations. What is your diagnosis? This is a case of acute pulmonary histoplasmosis. Let's take an in-depth look at histoplasmosis and its key clinical aspects. Histoplasma is a dimorphic fungus that displays characteristic narrow-based budding yeast at 37 degrees Celsius. It grows as mold in the soil and proliferates best in soil contaminated with bird or bat droppings, which favor sporulation. Exposure occurs when soil or droppings with a high concentration of spores are disturbed, as in caves or at construction sites. Infection is transmitted by inhalation of airborne fungal spores. There are 2 variants of Histoplasma capsulatum pathogenic to humans: Histoplasma capsulatum var. du Bois, which causes African histoplasmosis, and Histoplasma capsulatum var. capsulatum, which causes classic histoplasmosis. African histoplasmosis is a rare deep mycosis that usually occurs in the tropical belt of Africa and can involve the skin, subcutaneous tissues, lymph nodes, and bones. It rarely affects the lungs and is rarely reported outside of Africa. Classic histoplasmosis is found worldwide and can cause pulmonary infection or disseminated infections. Pulmonary histoplasmosis has a broad spectrum of presentations, from asymptomatic infection to life-threatening pneumonia. Acute pulmonary histoplasmosis typically occurs within 1 to 3 weeks of exposure and is usually self-limited. A diffuse miliary pattern on a chest X-ray in this case typically represents an intense acute pulmonary infection following massive exposure. This pattern is characterized by numerous, small, 1 to 3 mm, discrete, and uniform micronodules scattered throughout both lungs. For patients with impaired cellular immunity, dissemination may occur and may be fatal. Disseminated disease can involve many different organs, including the skin, central nervous system, gastrointestinal tract, joints, and adrenal glands. So, how does histoplasma reveal itself in the lab? Wheel starts with direct films and smears, which are generally stained with techniques that highlight the yeast cell wall within host cells, especially in samples from bone marrow, blood, or respiratory fluids. Grochid Gomori methenamine silver stain, or GMS, is considered the gold standard for staining histoplasma in tissue and cytological samples. It stains the yeast cell wall black or dark brown, highlighting the small ovoid yeasts. While fungal culture remains the gold standard, it requires patience, often taking 4 to 6 weeks from samples such as sputum, lung tissue, or bronchoalveolar lavage. Given the potential infectivity, these cultures must be handled with care inside a biosafety cabinet. Once colonies emerge, modern techniques like MALDI-TOF allow rapid and precise identification of the organism. On lactophenol cotton blue staining of the culture, hyaline thin septate hyphae are observed, bearing characteristic rounded tuberculate macroconidia along with smaller smooth-walled microconidia. Detection of histoplasma polysaccharide antigen in serum or urine can be achieved using enzyme immunoassay or lateral flow assay, providing a rapid and sensitive diagnostic approach. Detection of acute phase Histoplasma serum antibodies is performed using immunodiffusion or complement fixation tests, typically becoming positive within 4 to 8 weeks after exposure. These assays target antibodies directed against the M antigen, a catalase, and the H antigen, a beta-glucosidase. In addition, molecular diagnosis using PCR can be employed for rapid and specific detection. For symptomatic patients, treatment is indicated. Oral itraconazole is recommended for those with symptoms persisting beyond 1 month. In cases of moderately severe to severe acute pulmonary histoplasmosis, initial therapy with intravenous liposomal amphotericin B is required, followed by step-down treatment with oral itraconazole. When evaluating a case of acute pulmonary histoplasmosis, 2 key questions should come to your mind. What is the differential diagnosis of bat-associated infections? And what is the differential diagnosis of pulmonary miliary infiltrates on chest X-ray? When evaluating a patient with a history of bat exposure, several infections should be considered. Most notably, Histoplasma capsulatum is associated with inhalation of spores from bat guano, leading to acute pulmonary histoplasmosis. In addition, bats are important reservoirs for viral infections such as rabies, which is transmitted through bites or scratches and can cause fatal encephalitis. Other bat-associated viruses include Nipah virus, as well as the filoviruses, Ebola and Marburg, which are responsible for severe hemorrhagic fevers. In a patient presenting with pulmonary miliary infiltrates on chest imaging, the differential diagnosis is broad and reflects hematogenous dissemination of disease. The most classic and important cause is miliary tuberculosis. However, disseminated fungal infections, particularly histoplasmosis, should also be strongly considered, along with other endemic mycosis. Additional infectious causes include atypical pneumonia, psittacosis, and Q fever. Non-infectious etiologies must also be kept in mind, including miliary metastasis from malignancies, granulomatous conditions such as sarcoidosis, and certain occupational or hypersensitivity-related lung diseases. Ultimately, accurate diagnosis depends on integrating radiologic findings with exposure history, immune status, and targeted laboratory investigations.